So we're going to take a few minutes just to talk about the ADL Significant Change Report in PCC. We're going to talk about how to pull it, how to read it, and what it can do for you. It is a report that's in Point Click Care in the Clinical tab under Reports. Once you click there, then you can type in ADL in the little search bar, and it will bring up all of the ADL type reports. And in this instance, there's two, and they fall under the Point of Care. And you can just click on ADL Significant Change Analysis Report. By clicking on that, you will open up the setup for the report. There's no need to change any of these settings unless you want a specific patient, you're looking to do this for a particular unit, you want only a certain payer, so if you only want your Medicare payers or your Medicaid payers, then you can limit it in regards to that, and if you want a different look back period. But as it stands, whenever you pull the report, it's going to go back basically 1 month from the time that you're looking at on there. So you could change it back to 11/1, 10/1, whatever you wanted. But by default, it's always going to be the day that you're pulling the report, unless you change it, and that's fine. And then you would hit Run Report. Once you run the report, you're going to get the whole list of all the patients that were basically what you sorted by. If it was only a unit, if it was only a payer, if it was only a specific patient you were looking at. And the top of the report is going to tell you what all those selections were. So I looked for all residents, all units, all floors that are current in the building. And I looked from 11/23, which is the date that I pulled it. And they're telling you that the week 3 and 4 will be 11/10 to 11/23, and week 1 and 2 are 10/27 to 11/9. So you can see that it's going back 4 weeks. You can see all the payers that are in there. So then they have the names here, which I've blacked out for HIPAA. But what I want you to know is that when you're looking at this report, don't worry about these numbers, all right? So when you see it's 3, it's 3.4, it's 3.2, that really is nothing that you can look at and be able to come up with and know whether that's accurate or not. It's like when you're buying a house and they look at, what the neighborhoods are like, and they'll say the average family is 2.3. All right, same sort of thing. This is taking into consideration missing documentation, that there wasn't as many times that it was documented, different shifts, all of that. So don't pay attention to these numbers. But what you do want to pay attention to is this category line. And you want to pay attention to all of them, whether it says decline, whether it says same, whether it says improve. And then you can see that. So week 1 and 2, this is all of the information here in that kind of block for those particular ADLs. Week 3 and 4 is circled with the purple, and that would be the same for each of the patients, just so you can see which data goes with those 2 weeks. The first column here is RUG 4, and that's taking into consideration Medicare ADL scores, and then you have RUG 3, which is for some of the case mix states that use that RUG grouper to determine their ADL scores. But again, don't worry so much about the numbers and pay attention to these categories and the areas in which those categories are listing declines, same, or improvement. So you're going to ask, why do we care about same or improvement? Shouldn't we just be caring about the declines? Well, decline is not what you're looking for in bed mobility, toileting, transfer, and eating, for sure. And you don't want same when you're in transfer, locomotion on unit, or walking in corridor. You actually want improvements in those because those all have impacts on your ADL scores, your quality measure scores. So should we only be concerned about declines? Think about those quality measures, specifically the ones that are related to ADLs. Think about your restorative nursing programs. Think about your reimbursement systems. So when we're focusing on quality, the percentage of residents whose need for help with late loss ADLs, the daily activities of bed mobility, transfer, toileting, and eating, when you're seeing a decline in that, you're going to have an impact in your quality measures. That's negative. Percentage of residents whose ability to move independently worsened, and they define that as an increase in 1 ADL point of locomotion on the unit. So you want to make sure, again, that we're looking at that. So if those are worsening, we're going to be concerned about that if we see declines in either of these. Percentage of residents who show improvement between their 5-day and their planned discharge in transfer, locomotion on unit, or walking in corridor. So when you see the same or a decline in these areas, then you can be sure that you're going to see an issue with quality measures in that particular area. And what they do for that is they take the sum of the self-performance for those 3 ADLs from the 5-day and they compare it to the discharge. And unless there's an improvement, then you're going to trigger for that quality measure. You want those numbers to be higher. So declines can be indicative of other quality measure concerns. Is pain present? Are psych meds an issue? Are they now at increased risk for falls and therefore fall with major injury? And is the decline an indicator perhaps of an acute illness that we may be able to address and avoid ER or hospitalizations? Improvements can be supportive of your restorative nursing goals as well as the rehab interventions. You don't want people being on rehab and getting RU levels under Medicare or in your case mix, and then you're seeing that they're either staying the same or they're having further decline. Those improvements may be the first indicator that a resident is able to improve their independence in a specific ADL and perhaps benefit from rehab interventions. And same should make you question therapy and restorative interventions, goals, and discharge plans when patients are on a caseload with goals to improve. This report is expected to be pulled by your MDS coordinator weekly, and this is to allow them to add names to the resident round log, to identify and provide educational opportunities to line staff. So if you don't think that data is accurate and you think that the CNAs have miscoded, then you need to provide education. Assist with documentation related to restorative programs. So this can help you build your program. It can help the nurses do the documentation to support it and continue it. It can also identify opportunities for rehab intervention for, again, patient improvement as well as reimbursement systems, and assist with your quality measure outcomes. So there are lots of good things to come from this report. Use the tool. It's very valuable. If you question the data, then you need to fix it. Once it's trusted, we need to respond to it.